Hey everyone, and welcome to this explainer. Look, if you're tuning in, you already know the medical revenue cycle can be, well, a bit of a beast. It's complex, it's constantly changing, and honestly, it can be pretty intimidating. But today, we're going to completely demystify medical billing and coding. We're drawing from a fantastic, comprehensive A to V mastery guide by Cardiban, and we're going to build your understanding right from the absolute ground up. Whether you're studying for your certification or you just really want to understand how the money actually flows in healthcare, this foundational explainer is your roadmap. Okay, let's dive right into this. We're going to build your knowledge layer by layer today. First up, billing versus coding basics. Second, anatomy and medical necessity. Third, the shift to ICD 10. Fourth, compliance and unbundling rules. And finally, navigating the Medicare maze. All right, starting off with section 1, billing versus coding basics. People outside the industry love to lump these two together, right? But honestly, they're fundamentally different jobs. Billing is a highly interactive, people-focused role. If you're a biller, you are on the phone. You're working directly with patients, you're talking to clearinghouses, and you're dealing with insurance companies to push those claims through and actually secure the payment. Coding, on the flip side, is much more analytical. If you're a coder, your whole world is the medical record. Your job is to scrutinize the physician's documentation, like their operative reports or office notes, and translate that highly clinical language into very specific procedural and diagnostic codes. Most coders rarely, if ever, talk to a patient. You might ping a doctor to clarify a messy note, but your primary relationship is strictly with the paperwork. And when you're dealing with that paperwork, words matter. They matter immensely. You have to grasp these really subtle clinical distinctions to pick the right code. Let's look at illness versus disease. An illness is basically a state of mind or body where the patient might not even know anything is wrong. They might not feel sick at all. The source text uses a perfect example. A patient can have an illness like type 2 diabetes, but show absolutely zero outward symptoms. A disease, however, is an ailment that actively manifests with observable symptoms. It's actively interfering with how the body operates. Catching these tiny clinical nuances, that's exactly what separates a good coder from a great one. The same thing goes for the timeline of a patient's bodily harm. You have to know the difference between acute and chronic. Acute injuries are recent, accidental damages. The affected tissue is still fully capable of surviving. A chronic injury, though, is something that develops over a long period of time. It could be from continued wear and tear, the natural aging process, or maybe a wound that just never quite healed right. So why does this matter? Well, because the backstory entirely dictates the code. You can't just assume an injury is acute just because the patient walked into the clinic today. You have to play detective with the doctor's report. You're looking for key words. For example, if you see the word pathological, that's a huge red flag hinting at a long-term disease process, which absolutely points you toward chronic codes, not acute ones. Moving right along to section 2, anatomy and medical necessity. Okay, if you take one thing away from this whole explainer, let it be this. Medical necessity. It is literally the absolute bedrock of the entire medical billing industry. Medical necessity is the strict, uncompromising requirement that any operation or service performed must actually be required to diagnose or treat a problem, and it has to do so while maintaining an acceptable standard of care. This rule is here to ensure patients get the right treatments, but frankly, from a revenue perspective, it's the only way a claim ever gets paid. If you cannot prove medical necessity, there is no way the insurance company is opening its wallet. Zero chance. So how exactly do you prove it? Well, you prove it through diagnostic codes. The diagnostic code represents the actual illness or damage, making it, in effect, your medical necessity code. Every single procedural code, which tells the payer what the doctor actually did, must be inextricably linked to a supporting diagnostic code. Basically, the diagnosis justifies the procedure. If the why doesn't logically support the what, that claim is getting denied instantly. Next up, section 3, the shift to ICD 10. I absolutely love this analogy from the source material. VCR is to DVR what ICD 9 is to ICD 10. It's kind of funny, but it hits the nail right on the head. It brilliantly illustrates just how incredibly outdated the old system was. ICD 9 was your clunky old tape player constantly getting jammed. ICD 10 is the highly specific, digital, modern system that the entire global healthcare industry relies on today to track literally every disease and injury imaginable. To put that into perspective, just look at the staggering jump in the sheer volume of codes. Under the old ICD-9 system, we were working with about 14,000 diagnostic codes and maybe 4,000 procedure codes. When we shifted to ICD-10, boom, we jumped to over 68,000 diagnostic codes and a massive 72,000 procedure codes. The scale is just immense. To handle all that extra detail, the physical structure of the codes had to change too, expanding from 3 to 5 digits all the way up to 7 digits. So, let's actually break down how you decipher one of those 7-digit ICD-10 codes. It's kind of like reading a really specific zip code. The first 3 digits are basically your broad category, very similar to the old ICD-9 codes. Right after that third digit, you drop in the decimal point. But it's those subsequent digits after the decimal where the real magic happens. That's where you get the highly specific medical context. We're talking about things like laterality, meaning was the broken arm on the left side or the right side, or specifying whether the condition is chronic or acute. And if a particular code doesn't need all 7 spaces to describe the issue, the system just drops in placeholders to keep that uniform 7-character structure intact. It's a beautifully precise language once you get the hang of it. Which brings us to Section 4, Compliance and Unbundling Rules. You cannot survive in this industry if you don't respect the rule makers. First, you have the Department of Health and Human Services, or HHS. They are the massive umbrella organization dedicated to preserving Americans' health. Right under them sits CMS, the Centers for Medicare and Medicaid Services. They administer the largest public health programs in the country, which means they effectively set the rules for everyone else. Then there's the enforcer, the OIG, or the Office of Inspector General. Their entire job is to safeguard the HHS and ruthlessly hunt down healthcare fraud and abuse. They are always watching. Finally, there's the AMA, the American Medical Association. They are the ones who actually create, update, and hold the copyright to the CPT procedure codes that you use every single day. Speaking of the OIG, one of the biggest compliance traps you absolutely must avoid is called unbundling. CMS and the AMA predetermine which minor procedures are automatically included or bundled into the main code of a major surgery. Unbundling is the non-compliant practice of breaking apart those packaged procedures and billing them out separately, usually in an attempt to pull in more money. And look, sometimes it's an honest mistake because coders misunderstand what's packaged, but intention doesn't always matter here. Even accidental unbundling is dangerous and can trigger massive audits and severe financial penalties. But what happens when you actually have a legitimate reason? Say a procedure is normally bundled, but in this one specific, unique surgical case, it really was performed as a totally separate service. How do you bypass the system's edits, legally and ethically? You use a modifier. Modifiers are these brilliant little add-on codes that you attach to the main code. They serve to enlighten the payer. They basically say, hey, I know this looks like unbundling, but let me give you the specific backstory. This was a completely separate procedure today. It's how you accurately report unique situations while staying strictly within the rules. And finally, Section 5, Navigating the Medicare Maze. Medicare is the 800-pound gorilla of healthcare payers. It sets the benchmark that all the commercial payers end up following. But to bill it correctly, you have to memorize its 4 distinct parts. Part A is financed by our payroll taxes. That handles your inpatient hospital stays, hospice, and certain home health care. Part B is paid out via Social Security. That's your standard outpatient services and everyday physician care, and it typically pays about 80% of approved expenses. Then we have Part C, which are Medicare Advantage or private replacement plans. These roll parts A and B together, and they usually throw in extras like vision or dental. And lastly, there's Part D. This was added back in 2006, and it specifically handles prescription drug coverage. Now, while Medicare is the biggest player, you are definitely going to deal with commercial plans too, and they have their own crazy rules. Take the Exclusive Provider Organization, or EPO plan. These are super strict. Patients on an EPO have to choose a primary care physician. If they want to see a specialist, they absolutely need a referral first. And most importantly, they have to strictly stay within their network of contracted providers unless it's a literal life or death emergency. If you're a biller and you don't verify those exact EPO rules before the patient is seen, guess what? That claim is getting denied and your clinic isn't getting paid. So, here is what it all comes down to. Healthcare is an industry of relentless change. Every single year, codes are updated, old ones are thrown out, and Medicare policies shift. Earning your certification, that's really just day one. You have to ask yourself, are you truly prepared to prioritize continuing education? Because mastering this compliance maze requires a real, ongoing commitment to lifelong learning. You have to stay sharp to stay compliant. I really hope this explainer gave you a fantastic foundation to build upon. Please like, share, and subscribe to Decode Healthcare with Harshal.